right, good morning and welcome to the Palliative Care Friday Chalk Talks. Today we are honored to be joined by Dr. Charles F. von Gunten, who requires no introduction, who has probably trained many of us in the field or has trained our mentors, and he is the recent editor-in-chief at the Journal of Palliative Medicine. In the backdrop of his semi-retirement from some of his previous roles, we have an interview today that's reflecting on the past and the future of our field. And we'll have some time at the end for some questions from the audience. So, Charles, thank you for joining us today and welcome.
Thank you. I'm so delighted to be invited.
Absolutely. All right, let's jump right into number one. So, as you and I have talked, so you have some publications in a book chapter that sort of advises characteristics that you seek in emerging palliative care leaders so that we can continue to advance that field forward. And you've talked about modeling, selecting for personalities that have an assertive and insatiable curiosity. I love that. Who are seeking out interpersonal relationships, who seek out information at its source, face to face, instead of the communication from afar that we see so often now, and building relationships with people, that have a position to make changes. So if you had that famous magic wand that can change anything, how would you advise us as a field move towards that goal of creating that next batch of leaders?
The recognition that we need leaders in palliative medicine is broad. It's talked about people of my age, the issue that we don't have enough leaders, that there are so many chairs and program leader positions that are going vacant right now for lack of a suitable leader. So it's a huge topic. And the fundamental reason behind it is a demographic one, right? That place between those of us of my age and then the relatively junior people who emerged was about a 20-year gap. And so it's not unlike the baby bust that people are worried about broadly. So there's nothing to be done about that. Of the junior people who are eager and they're smart and they're the magic wand I'd wave is around their sense of fear. I brought this for whatever reason, and I'm not smart enough to know why, but there's something about the millennial Gen X. There's a fearful quality, and it's been attributed to the economic conditions at the time that they were coming of age. But I won't have enough. I won't have enough time. I won't have enough work-life balance. I won't have enough office space. I won't have it's all fear-based. And the characteristics that you listed that I put in that chapter, that they were not mine. When I was asked to write that chapter, of course, I went to the people I know that are good at this. That was a compilation of people who have a huge experience in recruiting and managing great people, and it was spot on. So all I did was put it in the chapter. But but of what you read, you could infuse. These are people who are not afraid of their environments. And they reach out with curiosity, not with arrogance, not with a need to dominate, but curiosity about the larger spheres around them. And that inner sense of confidence, of a spirit of abundance. I have enough time. I have enough energy. I have enough, and I'm going to reach out and help us fit in and grow. That's what my magic wand, that's what the little sprinkles would be.
So one thing I'm trying out next year with our new fellows, because we have now this thing called Secure Chat in Epic, where you can just instant message people, no longer having to talk face to face, no longer having to pick up a phone and speak. I'm trying to find a way to make it so the fellows cannot use it next year to try to promote some of exactly this in some way.
Well, I mean, you've got to me, a core issue.
Hmm.
And we can't change what the experience of COVID being remote. But I'm often asked, Charles, because people attribute to me the getting the new specialty, and the the to me it was no big deal. But the core skills I used, which it turns out are core leadership skills, when you go meet people, you go meet them in person. I was based in Chicago at the time, and it was the serendipity that most of organized medicine is based in Chicago. Now, I was at Northwestern downtown, and the offices of most of the people were either a 5-minute walk or a 10-minute cab ride away. Well, I would go see them in their offices. And one of the things that is generally true of doctor culture, particularly, is a physician will see any other physician. You get an appointment and you go see them in their office. And you start with an open-ended question. Tell me what you understand about hospice and palliative care.
Hmm.
And that willingness to go see people in person. When I started our first consult service, it turned out it was one of the early ones in the country. I made my business to go see the neurologists and the neurosurgeons and the cardiologists face to face. I'd track them down. I'd go meet. I wouldn't just telephone them. Using basic consultation etiquette, you talk to the person and you find out what they're looking for, what they're interested in before you start meddling with their patients. They built wonderful, wonderful relationships. And the key thing I learned in the effort at getting specialty status, there was nobody that was really opposed. I found lots of fear. Fear of being shamed, fear of being blamed, deeply aware of the poor attention to symptoms and end-of-life care among the surgeons, among the family physicians, among the psychiatrists, the neurologists, pediatricians, the worried that they would be somehow shamed or that we would beat them up in some way, as opposed to, oh, the goal is to try and make everything better. But you only establish those relationships in person. And so I still, when I am building programs, I'm working on something here, I'm making it, I will drive, I will go meet with people in person, and I love doing it over meals. My breakfast and lunch budget, because that's how you establish the basis for collaboration going forward.
What I need, I'm going to pitch for a breakfast budget here. I like that. So
So with it, we were talking before, I've failed my retirement and I've taken a new job. And there are good things about aging. And one of them is when I went in, I said, in all my other jobs, I did this out of my own pocket, but I want a budget so that when I'm inviting people to breakfast, lunch, or dinner, you're paying the bill, not me. And they said yes.
I love it. So in the past, we've debated names on this forum before. Palliative, supportive. There are many other names being pitched. In fact, a month ago, I just saw in the American Journal of Hospice and Palliative Medicine a pitch for eleology, the study of mercy, suffering, compassion, and that we are eleologists. You've lived through this. And so I'm curious what your preference for a name is and why for our specialty.
The rest of the world, the entire globe, calls the physician discipline palliative medicine. And so I would use that term for our specialty. But this gets into the science of branding and marketing. And so one has to ask, what are we using the name for ourselves, for others, for our clinical programs, and being clear what are we aiming for? Who is branding us? How is and the issue, this skewing over the name comes from those external audiences, by and large, who already have an association with the name and an attitude about what it means. That's very different solution or a different problem to be solved than what do we call ourselves when we're talking to ourselves. But that search for a name for ourselves, that has that same sort of hand wringing, oh, we're not good enough, we have to find another name. Oh,
Fear again.
and very fear-based. So the when I was in San Diego before, and so this was in the 2000s, and asked to start a palliative medicine consultation service for the NCI designated cancer center. Palliative care, and I'm trained as a medical oncologist, and so that helps me engage with that tribe. But that issue of associated with giving up, doing nothing was real. And so I wanted to name the service the Doris Howell Service. And the reason I wanted to, there is a long tradition in medicine, all doctors are aware of it, of naming clinical services for iconic physicians. And their legacy is the way they live on. It's not with a plaque, it's not with a room, it's not with a building. It's a clinical service that has arms and hands and hearts and continues their spirit. So Doris Howell was a pediatric hematologist oncologist who pushed for pediatric palliative care throughout her career and would say she had failed at it. She was one of the first physicians. She came out of McGill, she was at Duke, she was at Harvard, she was a dean, and yet in pushing for pediatric palliative care, she felt like a failure. When you said anywhere at UCSD, if you said Doris Howell's name, people would say, oh God, I love that woman. Well, wouldn't you want a service where anybody around says, oh, I love those people, that Howell service.
Yeah.
And I went to every oncologist in the cancer center when I started, and I said, I know that you know what palliative care is, that it begins at diagnosis and that it needs to be woven through. And I know that you know that there are other oncologists in this group who are afraid of the word, don't want to use the word. And so that's why I want to name it the Doris Howell Service. And to a person, 100%, me sitting in their offices, talking to them, sitting back in their chairs, that usual, oh yes, Charles. Oh yeah, I get it, Charles. I'm completely with you, 100% with you. And those, and those patients and those oncologists who have trouble. So I'm all on board with the Doris Howell Service. Now, across the years, it was no secret it was the Doris Howell Palliative Care Service. But what changed was it wasn't one of those palliative care services, it was our palliative care service. And we know what they're like, and we know that they won't come in here and start talking about stopping chemotherapy. So that ability locally to establish your brand identity, the feeling, and I think this, the supportive stuff came from Eduardo Barrera's publication of what would work at MD Anderson Cancer Center in Houston, and supportive care was easier. So this, instead of this search for what is the name that will bring us out of bondage into the promised land, I think what helps us develop our local identity with our referring physicians, that helps them develop confidence in us. And it's not going to be a name, it's us, how we behave, how we engage with those others. That's the core issue, not looking for a name.
Beautiful. In 2007, you wrote an editorial on the hidden real curriculum, but you wrote it from the perspective of just the field of medicine as a whole. And so, is there a similar hidden curriculum specifically embedded within just the field of hospice and palliative medicine that our fellows are observing in us, in their attending, so that are really not specifically intended to be taught by their program?
The hidden curriculum is a phenomenon that's been identified throughout education, not just medical education. And for anyone who has been around children, you know what the difference between what you tell your children
Oh boy.
and what they observe
Uh-huh.
that you and your spouse or
Mm.
the others in their environment do, and what they say and do is way more influenced by that than what you told them. So that's the core observation of the hidden curriculum.
Yeah.
It's always there, it's always being taught, and it is powerful. So the thing that pops to mind, David Weissman, when he was at Medical College of Wisconsin,
Yeah.
came up with the idea of full contact palliative medicine versus touch, using the analogy of football.
Yeah.
And you can see palliative medicine attendings drifting towards one or the other ends of those spectrum. Part of the hidden curriculum is, well, how do you behave when you're on the wards, when you're engaged with others? I've been to places where the palliative medicine attending only makes rounds at 8 o'clock in the evening, hiding, so that he didn't have to engage with other attendings. Could be just sort of, all right, what's the message for palliative medicine in the institution? The physicians that don't engage in direct conversation with others, if they're not seeing it done, it doesn't matter how much you want to talk about consultation etiquette, that you do it. If they don't see it done, the message is, well, this is another one of those things that you talk about and take the test on, but you don't actually do it in practice. So that willingness to take to hold up the mirror, how do I behave every day? How do I show up? Is it's powerful. But I'm remembering when I first, although everyone knew I had this interest in hospice and palliative care, when I became an oncology attending um, and had a 30-bed ward and, you know, fellows and residents. And I had a resident come up to me after about 4 days, 7 in the morning, Dr. Von Gunten, Dr. Von Gunten, that new admission in 1704. Now, his pain is not really under control yet, but I'm going to get there. And where did that come from? I never on that rotation said, if there's pain uncontrolled on morning walk rounds, there'll be hell to pay. I never said anything. How did this person pick up that I thought that was an important part of cancer care in oncology ward? Well, it was my own hidden curriculum. He could tell what I was paying attention to, what I thought was important, where my questions were directed, as opposed to other ways. And he wanted to please me, as all house staff want to please their attending physicians. It shocked me. I had no idea I had that kind of power to shape others by what I did, and had nothing to do with my conscious intention of transmitting a message. Each of us has that power.
Thank you. Yeah. We'd love to hear a case from you. Of course, being mindful about patient privacy, but something that has stuck with you and maybe something where you could share a few pearls of wisdom with us.
Oh, for me, the cases that most linger in my memory are the early cases. And the one that was probably most formative for me is very early. Guy was admitted to the hospital with lung cancer, metastatic lung cancer, and I was the oncologist, that needed to go see him as, consult to medical oncology for this finding. And of course, he asked me, Doc, am I going to die? And I said, yes, but not right away, because he was worried he was going to die like that week. He had a post-obstructive pneumonia. No. So of course I then saw him outpatient and followed up for treatment. The ability, so that was palliative care woven in from the moment of diagnosis and seeing the oncologist consultant. Pain control was an issue. He had bone pain, shortness of breath, fatigue, the shock of, he was in his 50s, young guy. He also found out he had AIDS, didn't know that either. So over the succeeding months, helping him throughout that course of illness. Now, was that medical oncology? Was that palliative medicine?
Just good medicine.
It was a synthesis.
Yeah.
So one of the things that bedevils, I think modern medicine now more than anything, this everything is in its own little column with its own specialist, its own place, as you say, in Epic, the either or language instead of the both and continuity through piece. Do you do that with one doc? Do you do it with a combination of docs? It all works, but the idea that we are practicing medicine, it's all part of practicing good medicine. Palliative medicine is a subspecialty of medicine. It's not different, it's not separate, it's part of the whole. That case, the relationship I had with his common law wife, his previous girlfriend, who found out she had AIDS too and didn't know. That web of people, that case is stuck with me. If anyway, I'm still trying to live up to the expectations, the outcomes of that in everything I do and in the programs I build.
In the interest of time, I think we'll jump to our last question, and I just want to let the audience know that if there are questions, we want to save some time for them as well. And Jake, I saw that you put something in the chat. So once I'm done with this one, we'll have you unmute if you're okay with that. So our final parting question is can you share with us a parting piece of positivity, something to give us hope for the future of our field?
Oh, I feel like I can die a very happy man because our field is launched. It is diffuse in American healthcare. It is now growing and developing all over the world. There is no question of our survival, of the sense that it is an essential part of healthcare. Where it goes, how it goes, the intercalations of our field of knowledge with the other fields that are developing, avoiding the traps. That's the landscape of the future. But the people that are involved, our fellows, our junior faculty, the people that are out there in the community doing this, they're wonderful human beings. And the broad, I don't hear anywhere anyone saying we don't need that. Usually it's we need it, we need more of it, and then we're into the competition for resources. What can we afford? What do we pay for? But that's different than do we exist? So because of the people that are in the field, that are coming into the field, it's fun for me when I encounter people. To them, there's never been a time when there wasn't a subspecialty of hospice and palliative medicine, and this wasn't integrated, and there wasn't a fellowship training path, and there weren't jobs. And it doesn't seem very long ago that people told me, Charles, that's impossible. So I'm deeply, deeply optimistic for the future of our field and the future of healthcare. But the key is in How do we intercalate, collaborate, interdigitate in medicine, moving us forward?
Thank you. Yeah. Jake, if you're able to, can you unmute and then Eve will have you go after Jake?
Yeah, absolutely. Charles, it's an honor to get to hear from you and know you a little bit. So I'm a chaplain, and I'm a chaplain at a hospice facility, and I work with the fellows quite a bit. And everything that you've been saying is so foundational in the field of clinical pastoral education, where we train chaplains.
Yeah.
And especially as you talk about what we've in the press referred to as like pastoral authority, but being able to claim your identity and claim your role, especially among other physicians, especially among other staff. And so much of it, from what I've heard you say, goes back to those primary emotions. You know, the shame, the guilt, the pride, the fear, all these emotions that drive behaviors. And I'm absolutely fascinated at how parallel this field is to chaplaincy. And I'm wondering, from your myriad of wisdom and experience, if you could share some of the best practices that develop that emotional self-awareness in you, that helped you really connect with other physicians, other patients, families. And then what are some things that you think are foundational for current fellows to practice in this related area?
Well, it should be no secret to you that, I've learned this from working on teams with really good chaplains and really good social workers and really good nurses. And so I'm thinking of I there was some family member that was just furious, furious at the doctors, furious at me. Um, and it was, I think, a chaplain that was like, grabbed me, Charles, can't you see he's frightened? No, I think he's angry, but can't you? And there's like, Charles, can't you see he's just like a little boy? And don't you know, little 6-year-old, when they're frightened, they come out with their fists. Well, I have no children. But I remember that. I remember seeing it. It was like, oh my God, my eyes were open to this. Oh, and you approach when you, just like little frightened little boys who are fighting, you approach them with an embrace, not by hitting back. Huh. So I did it. The behavior melted away. And that's been a pattern. So I learned that from chaplains and social workers who delve into this much more than in the training of physicians. But I'm teachable. I learn. So to me, the cool thing is, in the best fellowship programs, they have really strong chaplaincy, muscular chaplaincy, muscular social work, who are willing to take on the physicians in the same way that the people took me on, and were willing to say to me, even as an attending MD, PhD, Charles, you're missing the boat here. They did it thoughtfully, respectfully, not in public, but I'm so grateful for that kind of ability to be shaped. So that fundamental humility that we have things to learn, not from other doctors only, but from chaplaincy, because chaplaincy's discipline is deep, powerful. The thing I found challenging is, how do you find muscular chaplains that have that sense of confidence, that willingness to engage in both directions? Because the chaplains learning palliative medicine is as important as us learning about the who people are and their reactions to illness, guilt, shame. I'm still trying to figure it out, and grateful I work with smart chaplains who are better at it than I am. It's that sense of humility and curiosity to learn from each other, and being, one of the things that struck me most early in my training was how the, Buckman's 6 steps start with an open-ended question works in life. It's not just about patient care. That's starting with, tell me about you. Tell me about what you understand. Is the portal to knowing more about yourself, but by being curious about other people.
Thank you. Thank you.
Eve, we'll have you unmute, and then
Yeah.
after that, we'll have Rachel go, and then we'll conclude for the day.
Okay, thank you. And this was actually a perfect segue into my question. And first of all, it's an honor to speak to you. And full disclosure, I am a nurse practitioner. So I'm curious on the evolution of the specialty and the increased numbers of advanced practice clinicians, specifically nurse practitioners. What has been your experience, and kind of where do you see that going? And I will tell you specifically from a hospice standpoint, because I see a lot of opportunity there. It's just not they're not built into the team at this point. So any thoughts on what you've seen?
Lots of thoughts. I have failed retirement, and I'm now working for a hospice that currently has 8 nurse practitioners. And the challenge that I am most addressing right now is trying to help them feel like they're part of the medical staff, they're part of the team, pulling them in. The same issues of self-confidence, of humility, willing to work collaboratively with others. The best nurse practitioners that I've worked with are people who are deeply confident in themselves and their skills as nurse practitioners, because what nurse practitioners bring that's most helpful is not the mini doctor skills, the ability to prescribe. It's the deep connections to nursing and that synthesis of nursing and medicine that is so powerful in really effective nurse practitioners. So I agree with you. There is a tremendous opportunity, but the key is in finding the right people, the right personalities that will be good at being nurse practitioners in this environment. Well-educated, confident, curious, collaborative in nature, and it's so much fun. By being an oncologist, my first introduction to that kind of pairing was with oncology nurses who all practice in an advanced practice capacity, and that it's almost a fusion between oncologists and oncology nurses in the care of patients. It's a dance because of the complementary skills. That happens in our field as well, between nurse practitioners and physicians and the other members of the team. But again, it takes self-confidence in the part of the nurse practitioner.
Thank you.
All right, Rachel, you get to ask the last question for the morning.
Hi, Charles. It's a privilege to speak with you. I wanted to ask what your most formidable challenge during your career was that made the biggest impact, of which you are proud.
Say that again. Ask the question again.
What was the most formidable challenge during your career? Because you keep saying you failed retirement. So, but what was the biggest challenge of which you overcame, which you are most proud? So a challenging moment that was pivotal.
Well, the thing that pops to mind. So in the progress towards specialization, it was clear that the American Board of Internal Medicine would need to be the ones that proposed specialization to the American Board of Medical Specialties. And we had been preparing for years for the argument. Needed to be a body of knowledge. So we had the textbooks that, needed to be practiced, all the cognitive. And we were invited, Dale Lupu and I were invited to ABIM's meeting in Philadelphia, and they said, oh, we have a cocktail party and dinner the night before. You can come, making it sound social. And we got there. They were having cocktails outside on a terrace, and the chair of the board at the time came up, and he was already two martinis into the evening, and he just says, "Oh, welcome. This is where we do our real work. Good luck." And he walked off. And all of a sudden, I was like, "Oh my God, we have to work this cocktail party." This, I've heard about the decisions that are really made at parties and other, as opposed to the real meeting. And I thought, this is it. And we hadn't prepared. We didn't know. And Dale and I was like, all right, we got to split up. We got to start working this room. And I remember getting seated at a table between a dean of a medical school and there was a chairman of medicine on the other side, both of which were absolutely opposed to having this be a specialty, starting with the salad course and engaging with them, other people at the table. By the dessert course, they were willing to support it. So but that took the willingness to engage, the willingness to step in where I'm an introvert by nature. I don't go to a cocktail party going, oh, hoo, 100 new friends potentially. I shrink. So having to sort of just stand on the edge of the cliff and jump off, knowing I needed to do it, do or die. There are many of us have those kind of places. And for the rest of my career, when those things have occurred, when I've been invited with powerful people, recognizing it's the interpersonal, it's the making the connections, that's what's most important, including with the docs who seem scary, the chairs of surgery, the chairs of neurosurgery, no, it's all a big cocktail party and making connections. People are willing to listen.
All right, Charles, fellow introvert. I really appreciate your time today. It was a pleasure. Thank you.
Thank you so much for inviting me.
Absolutely. All right. Have a great weekend, everybody. Bye.